Thanks for having me. My name is Thomas. I'm one of the cardiology residents at Western doing a visiting elective at St. Mike's, and I'll be talking about prosthetic mitral valves. I have no disclosures. So I'm planning to talk about the history and types of prosthetic mitral valves, normal echo appearance, evaluating function, and then looking for the cause of the prosthetic mitral valve dysfunction. So in terms of a bit of history, the first valve prosthesis was put in the descending aorta to treat AI in 1952. It was a ball and cage design. And in 1960, the first ball and cage prosthetic mitral valve was implanted. They changed the ball from a methacrylate to nylon to reduce the noise that they were getting with the initial prosthesis in the descending aorta. In the 60s, they also started with the first bioprosthetic valves. Unfortunately, initially they had very high rates of early failure, thought to be due to immune activation to the xenoantigens. And so in the late 60s, they came up with the first of several treatment processes to get rid of those antigens that have led to progressively longer and longer survival of bioprosthetic valves in different positions. In the late 60s and early 70s, the tilting disc valves came out that had lower thrombogenicity and better performance than the ball and cage valves. Unfortunately, one commonly implanted specific type of the Bjork-Scheile valve suffered from a catastrophic strut fracture in about 600 out of the 80,000 implants, probably a little bit more by now, with unfortunately about 2/3 of the patients who had that happen passing away. In the 70s, the first bileaflet valves came out, with the first widely implanted one being the St. Jude bileaflet valve. And more than 1 million of these have been implanted with essentially no changes to design since it came out. And then the latest widely used mechanical bileaflet valve, the Onyx, came out in the 1990s. And you can see over here at the bottom right that the leaflet's open to a full 90-degree angle. Unlike the prior bileaflet valves. So what do mechanical mitral valves look like on echo? As we're all familiar, one of the hallmark features is a tremendous amount of acoustic shadowing. A tremendous amount of acoustic shadowing in different views, but in particular the apical views affecting the left atrium that can affect the ability to evaluate the left atrium, and in particular prosthetic mitral regurgitation. And you can see here on the TEE views, it instead affects the left ventricle. On Doppler, in addition to the filling patterns, opening and closing clips, these very prominent vertical lines are visible, and similar kind of clips are visible on M mode as well of the mechanical valves. So each valve has a kind of characteristic pattern of both filling and physiologic regurgitation. The bileaflet valve has 3 jets, but they usually merge into one on the TTE. The tilting disc valve has 2 jets with a larger, lower velocity one at the larger orifice, and then a smaller, often higher velocity one at the smaller orifice. And you can see them kind of separating here. And the ball and cage valves have curved jets that go around the ball, leaving a central wake in the left ventricle. Looking on TEE, it's easier to resolve the individual jets separately. So you can see in this case the 3 separate jets. On the TE here, and then a tilting disc valve here. Again, you can see there's sort of 2 separate profiles with a lower velocity jet on the left that stops aliasing earlier compared to the one on the right, and the ball and cage looks similar on TE. All mechanical valves have physiologic regurgitation, usually in the range of about 4 to 10 milliliters, and can be distinguished from pathologic regurgitation by having a narrow origin, being symmetrical, and having low momentum without significant aliasing in most cases. On the bileaflet valve, there are two main regurgitant jets from the pivot points that can split into multiple plumes, and then sometimes there's also additional small other jets around the perimeter. On the tilting disc valve, there's one large central regurgitation jet through this orifice for the central strut. And there might also be minor regurgitation around the edge. And then the ball and cage has closing jets at the perimeter of the ball as it moves back in early systole, and you can see those on some of the cycles in this loop here. Moving on to bioprosthetic surgical mitral valves. These are all stented, can be bovine pericardium or porcine aortic valve, and a small degree of central regurgitation is often seen even immediately after implant in a normally functioning valve. So this is an example here showing the prominent stented frame, as well as it's difficult to resolve them, but thin, pliable, mobile leaflets with trace intravalvular regurgitation. Looking here on this beautiful short axis views, you can see the three leaflets of the valve, and then the three kind of struts, like the posts of the stent that the valve is in, and again, the trace intravalvular regurgitation. Looking at the apical four-chamber view, there are similar findings with, again, that trace intravalvular regurgitation. And looking on a TEE, it's a similar appearance. I also have a few slides about transcatheter mitral valves, although I'll focus the rest of the talk on the surgical valves. Right now, FDA approved are the SAPIEN 3 for valve and ring procedures and being used off-label for valve and MAC. And then there were a number of experimental transcatheter valves for use in non-calcified native mitral valves. And the three that I've circled here are ones that I have some clips from Dr. Ong to show you of their typical appearance. So starting with the Tendyne valve here, you can see it has the large, very prominent appearing apical tether. Here's a zoomed in parasternal long axis, and then some color on it here. An unremarkable appearance, hard to resolve the leaflets. Looking at the short axis, again, you can see the frame of the valve, and again, hard to resolve the leaflets. And on color. And then looking at the this apical four-chamber, in this case, you can see the thin, pliable leaflets and the somewhat asymmetric shape of the valve intended to fit into the left atrium snugly. And here on color. And this is a different patient with the same valve implanted. And you can see in this case that there are thickened leaflets that still appear to open well, but are significantly thickened and of unknown cause. Moving on to the Edwards SAPIEN M3 valve, this one has a dock, and then the valve is implanted within the dock. The dock has this atrial turn, like a wire that you can see at the right side of the clip here in the left atrium, and then you can see the valve opening well. And again, here's the unremarkable color images. Looking on the apical four-chamber view on a transthoracic echo, a similar appearance, although harder to resolve that atrial turn of the dock. And then third, there's the Medtronic Intrepid valve. So this one has two, like the actual valve in the middle in this stent, and then this wider outer stent and skirt that holds the valve. And you can see the space in between the inner part of the valve and that outer stent and skirt, with a little bit of color flow into that space in between. Looking at it on a parasternal long axis zoomed image, in this case, the outer stent and skirt is quite bulky, and this patient had some LVOT obstruction related to the implant of the valve that resolved over time. Here it is on the short axis view. Again, you can see there's sort of two layers of stent in there. And then beautiful leaflet opening on this apical four-chamber view. with a little bit of what looks like trace intravalvular regurgitation versus contamination with the LVOT acceleration. So in the rest of the talk, we'll talk just about the surgical valves. Another frequent finding, especially with mechanical valves, is cavitation, bubbles in the LV that we're all used to seeing, which is a normal finding. And on TEE, another frequent finding are strands, these thin, mildly echogenic filamentous structures seen often on the LA side of the valve, move independently from the prosthetic heart valve, and can be distinguished from other either usually pathologic findings by having a somewhat different appearance compared to either sutures, vegetations, or thrombus. So I'm going to talk about a few parameters of prosthetic mitral valve function now, starting with the mean gradient. Which we're all familiar with this from evaluating mitral stenosis. Same story for the prosthetic valves. It's a heart rate dependent parameter with the typically published reference ranges usually being validated in the 60 to 80 BPM range. It'll be increased in both stenosis and in prosthetic regurgitation. And you can see here a rough idea of the reference ranges, but it is dependent, of course, on the specific valve. And each of the valves has different published reference ranges. And you can see that there's somewhat of a trend within a particular valve towards the mean gradient being a little bit lower with the larger valves, which makes sense. Measurements of the gradients and velocities are also affected by leaflet valves by flow through the central orifice. There's a small central slit-like orifice that has a velocity that's usually somewhat faster than the velocity through the rest of the valve. And you can see here an example of where in blue they've traced the profile through the larger orifices, and then in turquoise in the middle, the much less dense profile due to smaller amount of blood flow through the central orifice has been traced. This phenomenon is more prominent with smaller valve size and higher flow through the valve. So something to keep in mind that can affect the numbers that you get for the mean gradient and peak velocity. There are a number of pitfalls to evaluating gradients, things that can both under and overestimate severity. So underestimate Doppler beam not being aligned, which is usually not too big of an issue with mitral valves. A low flow state, of course, will underestimate the severity. The gradient will be lower, and elevated systemic blood pressure will reduce the flow and the gradient. Overestimating severity is more common and very frequently occurs due to a high flow state, such as sepsis. Contamination with aortic regurgitation or another jet is possible, although often can be separated by the different profiles of the jet. And then the central high velocity jet with bileaflet valves that I talked about on the last slide. And causes other than stenosis that do cause a true increased gradient exist as well, and those include patient prosthesis mismatch as well as prosthetic regurgitation. Peak velocity, just measured from the same Doppler, also called the maximum E velocity, is also increased in both stenosis and regurgitation. And again, here are some reference ranges for typical valves, although again, it varies somewhat according to the different valve. You can see there's a bit less of a trend towards it varying according to valve size, but the numbers are a little bit different for different valves. Effective orifice area is another number that is also affected by both stenosis and regurgitation. In stenosis, the idea is that it reflects the actual smallest orifice area that the blood flows through. If there's significant regurgitation, either in the mitral regurgitation or aortic regurgitation, it will cause the EOA to appear smaller, but that doesn't actually represent any physiologic reality. It's not that the orifice is actually getting smaller. So what I'd read was to not use it if there's more than mild AR or MR. It's calculated using the continuity equation, using the VTI of the CW Doppler through the mitral valve, and then the LVOT area measured from the LVOT diameter and the LVOT VTI. Of course, this has the usual pitfall of the LVOT diameter measurement. Another option in select cases, if the LVOT measurements are not reliable, is to use the RVOT measurement on short axis as well as the RVOT VTI. You can see here the rough rule of thumb was that less than 1 would suggest significant stenosis, but again, the EOA is significantly different for different valves, and also according to valve size, and is not the same as the is not the same as the actual size of the valve. Another number that's related to the EOA is the Doppler velocity index, which is just the ratio between the VTI through the prosthetic valve and divided by the VTI through the LVOT. This will be increased in both stenosis and regurgitation as well. It's somewhat less affected by heart rate compared to the parameters before. And the main benefit of this is that it's not dependent on LVOT measurements. And in general, the size of the valve and the LVOT typically have a somewhat linear relationship, in that your average person who has a larger LVOT will get a larger valve put in just because they're going to have a larger heart. And in particular, within a patient, we generally wouldn't expect changes to the LVOT size over time. So that allows us to get that source of uncertainty out. I think this is a parameter that's maybe been reported a little bit less frequently and used a bit less frequently for prosthetic mitral valves, but is definitely emphasized in the latest ASE guideline. And then finally, the pressure half time is a parameter that has the advantage of being increased by stenosis, but not expected to be affected by regurgitation, although it does have its own pitfalls, including difficulty measuring it, and also some other sources of error, such as intra-atrial shunts. And it's also affected by atrial and ventricular compliance and the heart rate. And unlike for a native valve, using the formula to calculate the valve area is not valid, so it can only really be compared to the reference range for the valve as well as previous values for the patient. And you can see here there's a general rule of thumbs, but also pressure half times for each specific valve are reported. So I'll start by talking about patient prosthesis mismatch. Of course, this is when a valve that's too small for an individual patient is implanted. It's less common in the mitral position than in the aortic position, and it has a consistent association with higher pulmonary pressures, but an inconsistent association with mortality or other hard outcomes in the mitral position. Defined by having a low measured EOA index, so the EOA divided by body surface area less than 0.9, suggestive of severe patient prosthesis mismatch in the mitral position. Of course, the challenge is differentiating it from other causes of a low indexed EOA, such as valve stenosis. So in order to diagnose it, the EOA should be close to the projected EOA for the valve. There should be normal leaflet morphology, mobility, apparent function of the valve based on its appearance, and it should be present on all echocardiograms after the implant. So a case of potential patient prosthesis mismatch I have here is a 44-year-old woman with Down syndrome who had an AVSD repair as a child and then presented with mitral stenosis, had a mitral valve replacement, but due to a very small mitral valve annulus, no prosthetic mitral valve could be fit, and a 21 millimeter aortic bioprosthesis was put in instead. After the surgery, after she'd recovered from the immediate few days after the surgery, at a heart rate of 74, she still had a somewhat elevated mean gradient of 9 millimeters mercury. However, you can see here that the EOA was calculated as being 1, which is within the normal range for this specific valve. However, the EOA to body surface area ratio was 0.66, suggestive of severe patient prosthesis mismatch. She then came in 3 months later, acutely unwell, with a heart rate of 110 and a mean gradient of 18, but a similar calculated EOA and a similar calculated EOA to body surface area ratio, so similar EOA index. Looking on the transthoracic echo at the time, you can see a hyperdynamic systolic function. The valve appears to be well seated. Leaflets look like they're opening well, although they're somewhat difficult to resolve on this view. And similarly here, you can see just how much smaller the valve is compared to the size of the heart. And there's significant flow acceleration and physiologic trace intravalvular regurgitation. And here the gradients. And so 1 year later, she ended up coming back, and at that point, her gradients had gone back to the abnormal baseline that they were at before. So there was some discussion about whether to do a TE, further evaluate the valve, see whether there might be any abnormal cause. Ultimately, of shared decision making with the patient, decision was just to observe it, and this was felt to be a case of unavoidable patient prosthesis mismatch due to a very small mitral annulus that was exacerbated by the tachycardia and hyperdynamic state a few months after the procedure. So in terms of evaluating the mechanism of valve dysfunction, there are certain specific things to look for on both mechanical and bioprosthetic valves. On mechanical valves, that includes the occluder movement, if there's a mass limiting the movement, and if there's restriction of color flow at any point. On a bioprosthetic valve, most common things to look at would be leaflet thickening, calcification, and mobility. And on both, if there are any masses or vegetations, and then if there's rocking of the valve. So I'll start by talking about some causes of increased gradients in mechanical mitral valves other than regurgitation. So what I'll call a mechanical mitral valve stenosis. Those would include thrombus, pannus, endocarditis, surgical material in rare cases, and in rare cases, structural valve dysfunction of the mechanical mitral valve, with the first three of these being by far the most common. So mechanical mitral valve thrombosis, of course, a very feared complication, presents either with a subacute to very acute presentation, ranging from shortness of breath to cardiogenic shock and critical illness. There's about a 0.5% risk per year, which is 5 times valves in the aortic position. And inadequate anticoagulation and pregnancy are often associated with it. There's a greater risk in smaller valves as well as the older ball and cage valves. So these are some examples here showing what it'll often look like. There's often a large mass with restriction of leaflet movement. However, the mass suggestive of thrombus isn't always visible. If it is visible, it'll have a soft echo density, often be globular and sometimes mobile. There will also be disappearance of the physiologic regurgitation at that part of the valve, and then development of central regurgitation instead is frequently present, and an increased gradient in the valve. In this case here, you can see in the first 2 frames, there's abnormal regurgitation in this bileaflet valve, and the right leaflet is stuck. There's increased gradients in frame C, in D and E. The same findings are shown on 3D TE, and then in F, gated cardiac CT was done that showed a thrombus which has low attenuation both on CT and on echo. This is a case here of a carbometics valve that was implanted. Patient presented with shortness of breath and increased gradients. You can see here on the apical four-chamber view, it looks like at least one of the occluders is moving, but it's hard to see if the other one is moving. And then there's a flow acceleration, but due to shielding, can't really evaluate for regurgitation on the zoomed in view. And the increased gradients of mean gradient of 15 millimeters mercury at 73 beats per minute. Moving on to a TEE, you can see here that the one of the 2 leaflets of this bileaflet valve is completely stuck and immobile. And there's no flow in, and also the washing jet has been lost from that side of the valve. In that specific case, the diagnosis was maybe thrombus versus pannus. A CT could have been done to evaluate it as in the last case, but because it was felt the patient would be an operative candidate either way, they were taken to the OR and ended up having a thrombus in that particular valve, although nothing was visible on the TE in terms of a specific mass. So another condition is pannus. So unlike thrombus, pannus has an equal risk with mechanical and bioprosthetic valves. It's a fibrous proliferation that generally occurs right under the valve at the level of the annulus. It causes more gradual onset of shortness of breath and will be less of an acute presentation compared to thrombosis. On echo, a mass may or may not be present. If it is present, and usually it'll be visible on TE, it's typically less prominent than a thrombus, but it's more echo dense than the thrombus, whereas the thrombus has quite a soft appearance. And then leaflet movement may or may not be normal, whereas with thrombus, leaflet movement will usually be abnormal. Leaflet movement may be normal for pannus. Here's a table here comparing pannus with thrombus, just emphasizing most of the things I mentioned in the last slide, with the pannus typically occurring relatively late after implant. Pannus isn't strongly associated with inadequate anticoagulation. A smaller mass, often more at the level of the valve and not extending into the atrium. If a mass is visible, the attenuation on CT will be higher for thrombus compared to, higher for pannus compared to thrombus. The pannus may or may not affect motion of the occluders, whereas thrombus usually does. And this is an example of a algorithm I found suggesting how to distinguish between the two. So on TEE, if there's normal leaflet motion but increased gradients, it's much more likely to be pannus. If there's impaired leaflet motion with a mass present with low echo density, then that's very likely to be thrombus. If no mass is present, then CT can be done. And if a mass is identified on the CT, signal intensity on the CT can be used, where if the Hounsfield units are higher, it's more suggestive of pannus, and lower, more suggestive of thrombus. So moving on to a somewhat different case here. This is an example of a bileaflet valve with, you can see the left occluder is completely missing, resulting in severe mitral regurgitation. In this case, the patient was taken fluoroscopy and again showed lack of that left occluder. Taken to surgery, and surgery was found to have fractured with embolization of the occluder to the iliac artery, which was found by fluoroscopy and taken out at a later date. And there are a number of other causes of structural mechanical valve dysfunction, which are luckily very, very rare, but do occur. And you can see here in another example of a fracture of a small piece of an occluder. So moving on to bioprosthetic mitral valves causes of increased gradients other than regurgitation, so what I'll call stenosis. Most common by far is structural valve degeneration, which is an expected degeneration of the valve over time. But they can also get pannus, endocarditis, rarely thrombus, and then other causes of valve dysfunction intrinsic to the valve other than structural valve dysfunction, which are quite rare with bioprosthetic valves. So structural valve degeneration has a number of risk factors. Patient factors include younger age, end-stage kidney disease, and traditional CV risk factors. And prosthesis factors include being in the mitral position, a small valve, patient prosthesis mismatch. There's appears to be greater longevity with the currently implanted bioprosthetic valves, and which I was reminded of every time I went on a website to try to find a valve photo of any of these valves. They're really satisfied with the studies. So I guess we'll see as time continues to go on what the longevity of what valves that are currently being implanted are. The typical hallmark is a combination of calcification and tears in the valve. However, about 30% of cases are non-calcified, which is really raises the question of what the mechanism is, and it's still uncertain what the mechanism of the structural valve degeneration is. Leaflet calcification and thickening are frequently found, and regurgitation is also quite frequent with structural valve degeneration. And stenosis does occur as well, although regurgitation is slightly more common than increased gradients, although frequently both of them coexist. And you can see here some examples of some of the cutoffs used to determine what's a significant change in gradients for when valves are being followed over time. So this is a case here of a patient with a bioprosthetic mitral valve replacement who came in with a worsening shortness of breath, and was found here to have an elevated mean gradient, actually as high as 24 millimeters mercury at a physiologic heart rate. And then, so hard to resolve too much from the apical four chamber view here. But you can see the flow acceleration, and no significant regurgitation is available in this case, or is visible in this case. A somewhat more zoomed view appears to show that the leaflets aren't moving very well. Hard to know if they're thickened or not. And here it looks like there's only trace regurgitation. And this patient was also found to have moderate AI as well as severe aortic stenosis during the study. So they had a TE done as well. The TE shows, you can see here, severely calcified, thickened, immobile leaflets. And you see all the shadow that's being cast by the calcium as well. And this is a slightly different angle, but showing very limited leaflet mobility with flow acceleration. But again, at the time of this study, essentially no regurgitation. Because of the coexistence of the severe aortic stenosis and severe structural valve degeneration, patient was accepted for both valve-in-valve mitral valve replacement as well as TAVI. And you can see here the valve-in-valve mitral valve replacement with the wire going through the atrial septum and crossing the valve. And then the SAPIEN 3 Ultra prosthesis being deployed with the balloon on the 3D reconstruction images on the right, with the final result here being excellent with the SAPIEN 3 Ultra, both in the within the bioprosthetic mitral valve replacement as well as one in the native aortic valve. So moving on to endocarditis, this can be associated with stenosis, regurgitation, or both of the valve. Of course, frequently vegetations are seen. It can cause dehiscence and rocking of the valve, and both paravalvular regurgitation as well as intravalvular regurgitation due to both vegetation interference with closing or leaflet destruction, which is usually the case in bioprosthetic valves. So we've all seen endocarditis, so I have a pretty dramatic example here of a bioprosthetic mitral valve replacement with this enormous vegetation prolapsing in and out of the LVOT and aortic root. And you can see there are increased gradients, but actually not much regurgitation in this case here. And then moving on to TEE, again, you can see there's a somewhat heterogeneous appearance, and it's a highly mobile mass that's really restricting inflow into the left ventricle. And then finally on the TEE, here you can see how dramatically it's going in and out of the aortic root. Moving on to bioprosthetic mitral valve thrombosis, this is a rare condition, but one that I think has been talked about a little bit more frequently recently. The greatest risk is in the first 3 months after surgery, but there are cases of it occurring a lot later than that. Echo findings include increased gradients. Significant regurgitation can occur, but is less common than in structural valve degeneration. Increased leaflet thickness, and also reduced leaflet mobility. So this is a case here of a bioprosthetic mitral valve replacement. You can see definitely thickened leaflets and reduced mobility in the zoomed in parasternal long axis, trace regurgitation and flow acceleration. And then moving on to the apical forechamber, again, thickened leaflets that appear to be minimally mobile, and similar color Doppler findings with increased gradient. So moving on to the TEE images, here you can see thrombus in the valve extending up onto both sides of the left atrium. And you'll note that the thrombus is quite soft on the echo, not very echo dense. And they say it has typical similar appearance to the left ventricle in terms of density, although like the ventricular myocardium, although I don't know whether that's really that visible at this image here. Definitely less dense than the endocarditis in the previous case, or than the calcium, of course, in the structural valve degeneration. Again, in this case, only trace or maybe mild regurgitation. And then you can just see from a few different views here to get a look at how much thrombus there is in different parts of the left atrium. So I have another case here, and I'll just get you to take a look at this for a moment. Think about what diagnosis you would give. And no need to add a chat or anything, but so this ended up being a case that they diagnosed as thrombosis. You can see the soft echo density, relatively regular globular masses. Patient was felt to be a poor surgical candidate and was treated with thrombolysis with an excellent outcome. You can see here that thrombus appears to have completely resolved with pliable leaflet motion. And then the patient was discharged with this transthoracic echo at discharge showing good leaflet motion of thin leaflets. They then represented a few months later with this finding, and I'll just get you again to take a look at it, think about what the diagnosis would be. So the diagnosis in the second case was an infective endocarditis. Patient ended up growing Staph aureus in the blood, and you can see here, it's just a good comparison, I thought, using the same valve in the same patient. On the left, the thrombosis, which is softer, more globular, less mobile, and then on the right, the vegetation, which is a little more irregular, more echo dense, and somewhat more mobile than the thrombus. So moving on to mitral regurgitation, it's a similar approach to that for native MR. And the latest ASE guidelines that came out have this chart that is very similar to the chart for native MR. So essentially, if they meet several specific criteria for either mild or severe MR, then the evaluation is done. If they aren't in one of those categories, they are likely to have moderate MR, and they recommend quantitation if possible. But the quantitation can be particularly difficult especially for mechanical valves due to shielding and trouble with resolving some of the jets. So the color Doppler parameters for MR, again, most of these are very similar or the same as for native valves. So of course on color Doppler, a large central jet or a jet that wraps around with a coanda effect, suggestive of severe vena contracta width of more than 7 millimeters. It's the cutoff with slightly different cutoffs being used in different guidelines. A PISA radius of more than 9 to 10 millimeters with the Nyquist limit lowered. And then the cutoffs with PISA quantitation are similar, but that can be a lot harder to do, especially with the mechanical valves due to shielding. And finally, if there's flow convergence visible at the normal Nyquist limit used for color Doppler, that is suggestive of significant harm. Moving on to the CW and PW Doppler parameters, if there's a low peak E velocity or if there's EA reversal, so the E wave is less than the A wave, that reduces the likelihood of regurgitation significantly, or I should say severe regurgitation significantly, and is kind of incompatible with severe MR because if it's severe, there should be enough blood flowing back that the LA pressure increases enough to increase those velocities. Similarly, the DVI can be used with a DVI above 2.5, suggesting severe if the patient is felt not to have stenosis of the valve. Systolic flow reversal in the pulmonary veins, suggestive of severe, and dense triangular jet on the CW Doppler. If a jet is available, probably more likely to be able to get it with a bioprosthetic valve, at least on a TTE. So, of course, the acoustic shielding is a big challenge. There's the least shadowing of the left atrium on the subcostal view. And also in the parasternal, you can look for color extending far into the LA past the shadow. And then some of the parameters on the prior slide are helpful for evaluating. And then the ones that I hadn't talked about on the prior slide are if there's an unexplained increase in RVSP, that could be suggestive of worsening prosthetic valve function, including MR. And if there's a dilated hyperdynamic LV, that also wouldn't be in keeping with MR as it would be for a native valve. So for intravalvular regurgitation, these are some of the more common causes, with a thrombus being a very common cause for mechanical valves, structural valve degeneration being the most common cause of bioprosthesis, and then endocarditis and thrombus sometimes being able to affect both. Paravalvular regurgitation can occur for several different reasons. early paravalvular regurgitation after the surgery. I'd always heard that having a paravalvular leak was a pretty rare thing in surgical valves. However, when I was reading it, they said that small paravalvular leaks were pretty frequent in the early post-op period. It's possible that TEs are not being done, or like the TEs that I was seeing at least were not being done that early after surgery. And then, as scar formation occurs and the tissue remodels, the leak goes away. But in any case, these weren't reported to be associated with any poor outcomes. If there's a large paravalvular leak, it can cause heart failure or hemolysis. And then a late paravalvular regurgitation, more suggestive of dehiscence, with the endocarditis being the most common cause. And obviously that's a severe problem that usually requires a valve surgery. So this is an example here of a tilting disc Medtronic Hall valve. You can see the peristernal long axis view. And you can see that there's some kind of color going on in the LA, but hard to really know what's going on. Again, here it looks like there's maybe some regurgitation just to the right of the valve on the apical chamber, but really difficult to make any conclusions. And you can see in this tilting disc valve, again, the two jets in ventricular diastole, one going through the large orifice and the other one going through the small orifice. And then here, moving on to the subcostal view, you can see outside of the shadow of the valve, it does look like there's quite a lot of red color in the atrium, but really hard to be certain what it is. Just a clue that there could be something going on. And then the gradients are somewhat increased as well. Moving on to the TEE, the TEE ended up showing that this patient had significant paravalvular regurgitation. You can see at the left here of the valve with the jet kind of going up and shooting around the atrium. And on the 3D TEE, it was at the posterior part of the valve. You can see the red jet at the bottom of the image here. And the patient, I think, went on to have an amplex or occluder placed in the leak. PW Doppler of the pulmonary veins was done, and you can see there's kind of some artifact on here, but was felt to have systolic flow reversal suggestive of severe MR. And in addition to the color of the coanda effect wrapping around the atrium was felt to be severe. So that's the end of my talk. I have some take-home points. First of all, increased prosthetic mitral valve gradients may be due to stenosis of the valve, high flow states, regurgitation, or patient prosthesis mismatch. DVI is not prone to errors in LVOT measurement and less affected by high flow states, and could be a useful option to look at. Unexplained increasing mechanical gradients with normal leaflet motion and no mass on TEE is most often due to pannus. And mechanical mitral prosthetic regurg can be detected on transthoracic by looking at the subcostal images and also by looking at hemodynamic consequences rest of the heart. Thank you very much for your attention, and thanks to Dr. Edwards, Dr. Ong, and Dr. Bliss in London for contributing some cases, and thank you, Dr. Chow, for having me. Look forward to any comments or discussion.